Hi guys, let's do GIGU lab. This is week number 6. Didn't write that in there. Week 6. Week 6. It is the spring of 2020. We are going to talk about percussion of the abdomen today. So last week and the week before we talked about observation, we talked about auscultation, and now it's time for percussion. This is the official order that you're supposed to go in. And why would you use percussion for anything? Mainly to assess the size and density of organs in the abdominal cavity, and also to detect the presence of fluid or gas or masses. We're really doing this to assess the percussion note. How does the abdomen percuss? I'm percussing right now. Remember 1, 2, 1, 2, our very first lab. Tympany, great. So it percusses tympanic. Not the whole thing, but most of it does. You can perform this independently or with palpation. So Seidel, one of the chiropractic board books, say you can go either way with it. You can do it. You can percuss a quadrant and then palpate a quadrant, percuss a quadrant. But we are going to go percussion all the way around the abdomen, and then we'll go and do, next week, we will do palpation. So you will percuss each of the 4 quadrants. None of the board books actually tell you exactly how to do this, which is interesting. So I think it's safe to percuss horizontally across the quadrant and then vertically across the quadrant, and that should pretty much take care of this. You're just looking for percussion notes with this. Palpation has higher sensitivity, much higher sensitivity and specificity, and even its sensitivity and specificity is not the greatest, right? I mean, in reality, if you're worried about something, you order an ultrasound, or you could order CT or MRI. But nevertheless, if you're out in the woods in Alaska or somewhere and there's none of this equipment around, you got to be able to do it like the old school. All right, your job is to assess the percussion note. As I said, it should be mostly tympanic. There should be a little bit of dullness. It shouldn't be like a drum the entire abdomen. You'd be worried about obstruction or some other, some type of viral infection or something causing gas or non-movement of fecal material. So it should be a little bit of spots here and there of dull. If you run into the liver, occasionally a liver is palpable. There's what's this called right here? I hope you know that. I assume you know stuff like that. That's the costal margin. We use that a lot in this class to talk a lot about the costal margin. So that's the costal margin. So you could run into the liver, we'll see, is about 3, could be up to 3 centimeters below the costal margin. You'll never hear a normal spleen, but if the patient has splenomegaly, you might run into a spleen. You might get dullness over in this region. Here, this would all percuss as dull in someone really, really thin, right? I mean, we'll see about 50% of people, you can't palpate this liver normally anyway, or percuss the liver, let alone palpate it. Did I say that right? Let alone percuss it. I don't know. Anyway, the entire abdomen, if the entire abdomen is tympanic or sticking out, that's protuberant, then you got to think there's something wrong, like obstruction is the first thing that comes to mind. But there's going to be other signs. The patient's going to be sick. They're going to have dyspepsia like crazy. They're going to have hyperactive bowel sounds maybe as the intestine peristalsis is ramping up to try to push through the fecal material. Or maybe it's late in the condition and they have no bowel sounds. Dullness over the flanks if the patient is face up. You can suspect ascites. Of course, they'll have a history of alcoholism, usually, or hepatitis or something that's caused cirrhosis. Flanks in a normal person should be tympanic as well. They shouldn't be dull. Although if they have some love handles and some fat, that's not going to percuss very tympanic. So that kind of messes up that system. All right, so percussion of the liver, I'm really more interested than that. And I'm going to try to make a demo tape here with my wife, if I can coax her into another one of these things. So when you talk about percussion of the liver, you're talking about really only two things. Where's the top of the liver and where's the bottom? So we're worried about the upper border of the liver, and we're worried about the lower border of the liver, according to both board books. We don't care, and we care about in the midclavicular line is where everything's going to be assessed. Don't care if it's off to the right or left. I mean, there's a 579 rule that I've seen on Spr20 25, but for us, everything's going to be assessed in the midclavicular line. All right, midclavicular line. So how do you percuss and I should go back to this. I mean, I guess I should probably make a slide on that. Let me make a note of that actually. Note, make slide. Because we really didn't talk about how to do it. So you would just percuss, start here. So here's, let's say his belly button's up a little higher. Let's say it's right here. So here's the quadrants, right? So you would just percuss this way, percuss, percuss, percuss. This is just called general percussion of the abdomen. Then you percuss, percuss this way. It doesn't matter which way you go. And that's enough. Then up here you would percuss, percuss, percuss. You might actually run right into the border of the liver here. And then percuss, percuss, percuss across here. Same thing here, as long as you kind of make a crosshairs in each region here of the abdomen, I think that is plenty good. Right? That's the way I like to do it. Kind of break it up into its own little 4 squares. 4 squares, and then each quadrant has its own kind of little 4 squares or 4 quadrants. Right, so that's how you would percuss that. Okay, we said now the liver, for whatever reason, you guys don't seem to do this one, the way the board books say anyway. Just like I said here, you're going to start from the bottom here. Let's see, can I get rid of this stuff? I think there's erase all the ink on the slide. So you're going to start down here, the midclavicular line. So here's would be the clavicle on each side. All right, we got the manubrium here in the middle. So the midclavicular line is right about there. Oops. So that's the midclavicular line. And so you would start percussing up like that. You don't percuss down. Why don't you percuss down? What's the normal percussion note of the thorax? Resonant, right? That's pretty close to tympanic. So your chances of detecting when the note changes from resonance to dullness are not the greatest. Go it all the way down like this. This is tympanic. This is dull. You got a decent chance of actually finding the inferior border of the liver. So you always want to percuss upward. And then 3 centimeter rule. So 3 centimeters, the liver could be normally within 3 centimeters of the costal margin in the midclavicular line. You got to memorize that rule. A lot of times the liver is underneath the costal margin, so you will never be able to percuss or even palpate it if that's the case. Okay. Okay, so we will start percuss the right lower quadrant and go superiorly in the right midclavicular line. As you near the costal margin, you might hear the note change from tympanic to liver dullness. I could have added there. Slide number 9, add liver dullness. All right. Then you're supposed to take a pencil and mark where you hear if you happen to hear it, 50% chance, they say. If you do hear it, you could take a marking crayon or a dry eraser or whatever and mark them, because we have to measure a liver span. And that's part of this is leading to a liver span measurement of how big the liver actually is. The distance between the costal margin and the inferior border should never be greater than 3 millimeters. So as I already said, so liver dullness should never be greater than 3 centimeters below the midclavicular line, costal margin on the right. If it is, it could indicate hepatomegaly, but we can't be 100% sure yet. We need to check that. I need to put a note on that too. We need to check that superior border, because conditions like COPD, right, where the lung, especially with the emphysema, that can cause overinflation of the lungs. The little acini, the walls between them and the alveoli, they break open, and 2 alveoli became 4, and 4 become 8, and 8 become 16, and they grow exponentially into a dead airspace it's not very good at gas absorption, and that will slowly push the entire liver down. The liver span will still be normal because there's nothing wrong with the liver span. It's COPD pushing down the liver. All right, so that's just kind of already said that. You start down here and you percuss upward, and the rule is if you run into some dullness, get your tape measure out, find the inferior costal or the costal margin here in the midclavicular line, and measure. It better not be greater. If it's like 4 or 5 centimeters they probably have enlarged liver, hepatomegaly. But before you say that, you better go find the top border, and that should be in the 5th intercostal space. In reality, why is this so hard to do? What happens if you percuss over a rib? It's going to be more dull, right, than resonant. So this is really, I do this stuff all the time, and for me it's even hard finding this stuff, so I can imagine for students. But nevertheless, you have to learn it. So don't feel bad if you can't feel this stuff or palpate this stuff, because it's really subtle. All right, so we talked about that. Too large an inferior border, or too low an inferior border. Let me change. I've got these. I haven't had this class really all that long. Haven't had time. I had 0 slides when I started this class, right? So these are all brand new. Too large? No. Okay, so if it's below 3 centimeters, we said, then you suspect hepatomegaly from things like lymphoma, leukemia, or cirrhosis, early cirrhosis. And conditions that cause early cirrhosis, like hepatitis, some authors say A in there, but most of the board books don't include A for whatever reason. But hepatitis B, C, and D, or alcoholic or non-alcoholic fatty, where you get a fat accumulation in the liver, they all destroy the liver and cause scar tissue, and that's cirrhosis. So that's a good question, right? 3 answers. All of the following are causes of hepatomegaly except blank. Emphysema. So that's your COPD, right? Emphysema. What is COPD? Did you guys have that before? Chronic obstructive pulmonary disease. That is the main category. It has emphysema and chronic bronchitis. But emphysema in particular, as I just described, it loves to create dead, huge pockets of air space that doesn't do anything, and the lung gets bigger and bigger, and it gives you a barrel chest, and it pushes the liver down. So be careful of that before you run off to that conclusion. You got to check that superior border as well. Now let's do it. Let's check the superior border of the liver. So now you're going to start in about the 3rd intercostal space, or even the 2nd is fine. But the key is you're going to go down in the midclavicular line on the right, and at the 5th intercostal space, normally the percussion note should change to dull. Try to go in between the ribs, right? If you hit a rib, it still might be semi-resonant, but it's not going to be as resonant if you percuss between in the intercostal spaces. Okay, that's the normal top border of the liver. Take a pencil and mark it if you find it. Right, so start up here. You can start in the 2nd or even the 3rd intercostal space. Come down. Females, you have to have your patient grab the breast with their own fingers and pull the breast toward the shoulder. Get it out of the way. And yeah, come down and find the border. Draw a line, and we draw a line down here. Let's say we've actually heard it here. And then the next step, we're going to get our tape measure and measure this. And that's called the liver span. The liver span. Okay, the upper border, if the upper border is below the fifth intercostal space, then there's a couple things to suspect. Maybe the liver is shrinking, right? So early cirrhosis, this is important. Early cirrhosis makes the liver big, full of scar tissue. But as the liver completely dies and sections of it die and are eaten up by the inflammatory responses, the liver actually shrinks. So late cirrhosis, you'll actually shrink the liver. If the upper border is above the fifth intercostal space, then think something is pushing the liver up from below. It could be like maybe they're pregnant, or they have a huge tumor, or a big, or ascites even from cirrhosis pushing it up. Remember the normal borders of liver dullness in the midclavicular line. So you got to memorize this. Upper border is the fifth intercostal space, all on the right, of course. Lower border is 3 centimeters is the limit, inferior to the costal margin, again in the midclavicular line. All right, now we talked about it. Let's meet officially the liver span. So a normal liver span is the magic number 9. This is the strangest set of numbers because they all have to do with the number 9, as we'll see. But a normal span, what's a span mean? You take your tape measure from here down to here, it should be about 9 centimeters. If they're tall, it might be a little bit bigger, but on average, about 9 centimeters. Got it? Simple as that. Right? The magic number 9. So it's a vertical measure of the liver in the midclavicular line. It's basically measure the upper and lower borders that we just palpated. And number 9 is weird. First of all, liver span. Watch how weird this is. Liver span. How many letters are in there? 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, 9. So the liver span is typically 9 centimeters. Okay, now what about the maximums and minimums for this? If you turn the 9 upside down, what does it become? 6. Right? So the liver should never be less than 6 centimeters. Now, if you turn it back right and you add the 6 to the 9, you get 15. So the maximum liver range, it should be the span should never be greater than 15 in your average size human, unless you're super tall. That kind of throws it off, but we won't worry about that. So got it? Testable. Make sure you know this stuff. Can almost guarantee you it's going to be on the lab test. Most of you did pretty good on this one. Or was this the one you didn't? No, you did good on this. You didn't do as good on GIGU for whatever reason. Oh, no, you didn't do as good on CVPP. That's more developed class. That's got more stuff in it. False positive for liver span. It's generally a little greater in males, especially in tall people. Now, if you have pneumonia, lower lobe pneumonia on the right, and a pleural effusion associated with that pneumonia, you could get a false positive. The percussion note, because of the infusion, may be way above the fifth intercostal space. If both conditions usually cause dullness. Yep. Okay, pleural effusion can cause dullness. Or fun facts, the border of a normal liver are difficult, if not impossible, to percuss. This is true. Only about 50, now this is Bates, only about 50% of normal livers have a lower border that can be palpated, and that's palpated. Percussed is probably like, I'd say 30% chance of finding one. I do it all the time, as I said, teach this class for quite a while, and it's very hard to find. In patients with true hepatomegaly, I'm told, and I've read, and if I listen to Bates, then the borders are actually much more easily percussed and palpable. What's normal? We already said normal. Liver span is the magic 9. Normally it's 9. But if it's greater than 9 plus 6, 15, makes the diagnosis of hepatomegaly. If it's less than 6, it makes the diagnosis, most common one would be late cirrhosis of the liver. Or it could be air obstructing diseases like a perforated bowel, which falsely takes away that dullness, because you might get some air up between the abdominal wall and the liver extending down. So an obstruction could also cause massive air buildup in the intestines and mess that up. COPD we talked about, so chronic obstructive pulmonary disease, parent category, 2 subcategories, emphysema, chronic bronchitis. Some big medical pathology texts are adding chronic asthma, which is, from what I have read in the research, is a good idea, because usually there's a mix of all 3 of these conditions, like an emphysema predominant COPD, or there's a mixture of all these, but for chiropractors it's only emphysema and chronic bronchitis. And we said it, especially in emphysema, the acini, which is the respiratory unit where the alveoli are, the walls of those degenerate and they start coalescing. Because here, let's say here's an alveoli doing gas exchange. Here's its neighbor right here. These guys are doing gas exchange, and here's an acini right here coming up. So COPD is kind of an inflammatory type condition where you get destruction of this right here. I don't think I can erase this, so I won't try, but this now is one big one. And if that happens with its neighbor, it gets bigger and bigger, and this space is now dead and doesn't work very good. So the lungs get really big. You get barrel-chested. Well, let's talk about that more in CVPP. And that can push the liver way down. Right? Liver's in the abdominal cavity. The lung is in the thoracic cavity, right? So it pushes the liver down. I like this slide. What causes hepatomegaly? So I want specifics. I don't want you to just say cirrhosis. So alcoholic fatty liver disease. Non-alcoholic fatty, so a fatty liver. The von Gerkes, or von Gerks, however you want to say that. The glycogen storage diseases, where they store too much glycogen, can blow that liver way up and cause destruction. Hepatitis A, B, C, and D. Sleisanger leaves off D. Bates left off A, so it's probably A, B, C, and D. AIDS, HIV could do it. And the leukemias, the lymphomas, primary lymphatic or metastasized cancer that's metastasized to the liver, they can all blow that liver up. Here's some other rare things. Not too interested in this slide, but biliary cirrhosis, porphyria, really rare condition, can't go out in the sun, sarcoidosis, sickle cell, Wilson's disease. Assessing ascites. So there's a couple of tasks I might ask you to do. I might say, I want you to percuss the abdomen to rule out ascites. That's exactly what I'll say. So you're going to do the horseshoe pattern is what you're going to do. Ascites, of course, occurs if there's a beaver dam in the liver. We've talked about it a million times, so I'm not going to go over that. But the beaver dam, the hepatic portal blood supply has to get through the liver. So does the inferior vena cava. If the liver's all scarred up, you can't push blood through it, so you start getting a backup. The intestinal veins and all the little veins can start leaking fluid into the interstitium, and they can get into the pleural cavity, and you can collect fluid in there. So how do you test for it? The classic horseshoe dullness pattern. Make sure you know how to do that. It is super easy. Oh, here's how you do it. Let me just show you. So you start at the belly button and you percuss out. Tympanic, 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 thud, dullness. Get your marker, make a mark. Tympanic, it's like spokes of a wheel, thud. Palpate, palpate, tympanic, thud. And pretty soon, these thuds are going to make a horseshoe. If you go this way, the fluid's not going to be there. You'll go all the way to the costal margins. So you get a horseshoe pattern of dullness. In the supine position, they must be supine, right? Must be supine. Did I say that over here? So they could go to that. Okay. How's that belly look? That's a great video. Go. That thing's been taken down, but it's back up and then it's down. I think it's a free clinic in India. This guy can really percuss. But it's a great demonstration. This is an alcoholic who's wrecked his liver from drinking. And the liver is the beaver dam. And blood can't get through. And so the interstitium in the peritoneal cavity just drenched in fluid. Turned his belly button inside out. Great video. You guys should watch it. Okay, but notice the flanks are bulging out. I mean, his ascites is so bad it's actually kind of coming out of the plane of the page, so it's easy to see. But how are you going to do this? Are we doing this? Yeah, let's do. Where's fluid wave test? Oh, I guess we haven't come to it. Let me keep following my slides. So the shifting dullness test is a way you could do this. So if you're percussing and you hit dullness here, if you want to confirm that that dullness is really fluid, what you do is you have the patient flip on his right side in this situation. That's called the right lateral decubitus position. And then give him a couple minutes and then re-percuss this region. What do you think you'll find? The fluid's all going to run downhill because of gravity. So this will become tympanic once again. That's called the shifting dullness test. SDT, shifting dullness test. Positive for ascites. There's the patient in the right lateral decubitus position. Right lateral decubitus position. We're making note of 32. Yeah, so if this is if it percusses tympanic, and it was just a second ago or just a couple minutes ago, it was dull, they got ascites. This is actually a fairly accurate way of testing this. Then we have the fluid wave test is classic here. You can read about it. Let me just show you. You have the patient put a kind of karate chop across the front and push down. That's going to form a barrier. And then you can either do kind of like a tap. I'll show you how to do that in lab. If I let my wife, hopefully I can get her to do it. Or you can flick them. This doctor snaps the finger. I don't know if that might be a little insensitive. It might hurt a little. But the key is to make a noise. And sound travels through water really good. So that sound that you create, that vibration, will hit your other hand if they're filled with fluid. If they just have a fat belly, well, even a fat belly, the reason you do this is because fat is pretty high water content as well. So if you push this down in the midline and snap it, any water kind of transmitted through the fat will be stopped right here. The fluid, the peritoneal cavity, is way deeper than this. Remember, the fat's in the subcutaneous tissue. So this takes fat kind of out of the equation. It's the theory on this, right? So if you can feel it on this side, it's positive. They have ascites. You don't have to do it on the other side. There's no reason to do it. Once it's positive, it's positive. Got it? That's called the fluid wave test. And everything I just said, yeah, poor sensitivity and specificity for these tests though, but nevertheless, if you're out in the woods in Alaska, we still have to have some tools, and these are the most basic tools that we have. All right, see you in the next video.